How are you?
So, good morning, everyone. I'm Philippe Diodet, and I'm happy to co-chair this session with Castriot Castrati, a session catching your breath, unraveling rheumatoid-associated interstitial lung disease. So this will start within 1 minute. Please turn off your phone.
Yeah, so hi everyone. I'm happy to introduce our first speaker, which is Professor Pierre-Antoine Jouge from Bichat Claude Bernard Hospital from Paris, France. Clinician, but also absolute expert on genetics and environmental risk factors in rheumatoid arthritis associated interstitial lung disease.
So thank you for the introduction, and it's my pleasure to be here. Here are my disclosures. So I would like to start this session by introducing two cases scenario. The first one is about a 68-year-old male. He's a past smoker, heavy smoker, and he has been diagnosed for RA 20 years ago. He's on remission using methotrexate currently. And he has also been diagnosed for ILD for 12 years. As you can see on the CT scan, it's a UIP pattern. And it's a progressive ILD. We are following up since 2014. And at this time, FVC was normal, as you can see. GLCO was slightly decreased. And over time, it progressed. And now it's about 68% of FVC and 37% of GLCO, which is quite low. He is progressive, although he's taking nintedanib, an antifibrotic drug. And he has been referred to our center for a pre-lung transplant workup. The second case scenario is a 75 female. She never smoked. She also has a seropositive RA for 40 years, and she also is in remission using abatacept. She has been diagnosed of ILD using a CT scan, which was performed for another reason. So it's an opportunistic diagnosis of RA-ILD, and it's asymptomatic, non-fibrotic and SIP, very stable over time, and we have followed her for 10 years. And over 10 years, her PFTs were stable with a normal FVC, and GLCO was slightly decreased and stayed stable over time without any antifibrotic medication. And she's just followed up using PFTs and sometimes HRCT scan. So what those two cases have in common, where they're both considered to have RA-ILD. So is it one or multiple disease? Well, spoiler alert, it's not one, but clearly multiple diseases. So RA-ILD is an umbrella condition, and I think today there are no clear definition of what RA-ILD is, so it's often hard to summarize it in one sentence. To my point of view, it is any interstitial lung abnormality or disease occurring in a patient of RA. There is a current debate of whether small, very small, non-extensive interstitial lung abnormality should be considered as a disease, but this is a debate. And of course, there should not be any differential, any alternative diagnosis. For an example, this patient is a 26 female with a ACPA, a seropositive RA, that presented to the ER for a rapidly progressive short of breath. As you can see, the CT scan presents some NSIP and OP features, which is not frequent in RA. The rapidly progressive course is also infrequent in RA. And we performed autoantibodies workup, and she was tested positive for anti-GO1, which means she had an antisynthetase syndrome associated with RA. So this slide is very important to remind you that there is a crucial role of the multidisciplinary team discussion. In my center, we do it every week, and it includes rheumatologists, pulmonologists, radiologists, pathologists, and thoracic surgeons in order to confirm that the diagnosis is RA-ILD and not other kind of ILDs occurring in RA. So RA-ILD is clearly heterogeneous. It's heterogeneous in terms of ILD pattern. Compared to the other systemic autoimmune rheumatic disease, there is a high prevalence of the UIP pattern. There are also an SIP pattern and other patterns, which means that the inflammation and fibrosis widely varies across patients in RA-ILD. It also varies in terms of ILD progression, and in this international multi-center cohort that we performed several years ago, we included 261 patients. And you can see that the gray spaghetti plot represents every patient's individual PFT course. So you can see that there is a lot of difference between patients since RA-ILD diagnosis. And we try to model this in one trajectory, but it's clearly heterogeneous. In another study that I participated in from the Massachusetts General Brigham in Boston, 168 patients, we tried to modelize this trajectory in 3 groups. And we observed 3 different trajectories. Patients who improve their PFTs in 32% of the patients, patients who slowly progress, about half of the patients, and rapid progression in 40% of the patients. It's also different in terms of genetic background, and you have here represented what I think the genetic of RA-ILD is. You've got the MUC5B promoter variant, which is a common variant that the T-risk allele is observed in 30 to 40% of the patient, which means that 60 to 70% of the patient does not have this T-risk allele and have other genetic risk factor. There are also rare variants in telomere-related genes, and I presented some results about that yesterday, which are observed in approximately 10% of the patient, which means that 90% of the patient does not have such variants and have other genetic risk factors. So why is it important to identify specific phenotypes, specific endotypes in RA-ILD? Well, first, it helps us to better understand how the disease occurs in patients with such different inflammatory and fibrotic mechanisms. It's important to identify those mechanisms, those pathways, to identify new drugs. It's also important to identify patients with poor prognosis, to be able to early recognize patients that are high risk to progress or die. And it's also important to have identified patients in which drug could be efficient, so identified specific profile with specific drug response to support targeted therapy. One thing that is sure is that there is an ERA-UIP endotype. There is a specific genetic architecture for ERA-UIP, the MUC5B promoter variant that I told you about. The association is restricted to the UIP pattern, and we often does not find it in non-UIP patients. And the telomere genes, the variants in telomere genes that I told you about also, the signal is stronger in ERA-UIP, and we could not find any significant signal in non-UIP patients. There are also some specific clinical risk factors, and this is a study also conducted by the team from Boston. They tried to look for clinical risk factors associated with ERA-UIP or ERA-NSIP to compare to non-ERA-ILD patients, ERA patients without ILD. And you can see that age and male sex was specific to ERA-UIP and were not associated with risk of ERA-NSIP. There is also a poor prognosis that is kind of specific to the ERA-UIP endotype. In this study from Denver, you can see that the NSIP patient had a better survival than the UIP patient that had a poor prognosis. It has also been identified in a Korean study where the team has followed up ERA-ILD patient over time, 5 years, and they looked at the scanographic and functional progression. And in this study, the UIP pattern was associated with progression when adjusted for age and sex. There is also a specific response of ERA-UIP to pirfenidone, and this is an antifibrotic drug, and this is a randomized controlled trial including patients with ERA-ILD. You can see that the response to pirfenidone was only observed for the ERA-UIP patients, and the non-UIP patient did not answer to pirfenidone. So what about a non-UIP pattern? Well, it's well used in the literature to compare UIP to non-UIP, but I think this is too simple, too simplistic. And why? Because it's an overly broad label. It includes a lot of different ILDs, including NSIP, organizing pneumonia, lymphocytic interstitial pneumonia. It includes fibrotic, non-fibrotic ILD, but it also overestimates the HRCT classification. Pulmonologists know that in patients, sometimes you can see NSIP feature. If you perform a lung biopsy, you will find UIP on pathology. There are also some patients, as you can see on this CT scan, who have like small non-extensive ILD that will not be classified as non-UIP in the literature, but is actually too small to have any conclusion, and maybe over time it will develop a UIP, so it may be a UIP patient at the end. And also it has been recognized as a new recommendation for ILD classification, but there also can be combined patterns. So mixed UIP and non-UIP patterns in the same patient at the same time, but also over time, some patterns will progress from non-UIP to UIP or UIP to non-UIP, and it's hard sometimes to classify patient as a UIP, non-UIP. So over pattern, could some specific HRCT features help us to predict survival? Well, we have a British cohort, including almost more than 150 patients with ERA-ILD, and it's interesting because it's performed by radiologists. And they looked at specific features that were associated with mortality. ILD extent, fibrosis extent, reticular pattern extent, or honeycomb extent. There were some patterns specifically associated with survival in ERA-ILD. And you can see that it helps stratification of patients. In black, you've got the IPF survival. In blue, you've got the UIP with a severe feature, bad outcome feature, which has a similar survival to IPF. In yellow, you've got the non-UIP with non-severe ILD, which got a way better survival. And in red, you've got the intermediate survival, which were either UIP without any severe feature or non-UIP patterns with severe feature. However, there is a current unmet need about how we can predict ILD progression, not survival, but progression. In the study that I told you about, a cohort from the Brigham Hospital in Boston, 168 patients, and we model group trajectories. No clinical feature were significantly associated with one of those profiles, except for the FVC at inclusion, which means that we could not identify any specific feature for one of those trajectories, so we could not predict which patient would belong to any of those trajectories. The Veterans Affairs and the team from Bayern, England, at Nebraska in the US also performs this kind of analysis in their Veteran Affairs patients. So it's area ILD among patients from the Veterans Affairs. More than 1,000 patients, and they also find 3 different group trajectories: a stable trajectory in approximately 18%, slow progression in 75%, rapid progression in 6%. They did find some specific feature across group, age, male, that were more associated with progression, and smoking that were associated with rapid progression. However, you can see that it was not very clinically significant. It was significant because of the number of patients included, but look at the age, 66 years old compared to 68, 90% of male compared to 93% of male, and also smoking was not very different among group in terms of clinical significance, so it was hard to predict a specific profile associated with progression. Unlike in IPF, the MUC5B promoter does not predict RA-ILD progression, and that's what we observed in our international multicenter cohort, where the T-risk allele was not associated with a lower or a slower or higher decline of FVC or DLCO. What about biomarkers? It may be interesting to identify a specific profile associated with progression, and in the Korean cohort, adjusted on age and sex, baseline KL6 and SPD biomarkers was associated with progression. Can we predict response to antifibrotics? I told you that UIP pattern was associated with a better response to pirfenidone. Well, we can't say that for nintedanib, where both UIP and non-UIP patterns seem to respond to that treatment. For nerandomilast, a new antifibrotic drug, it may be also the case. You can see that at the dose of 9 mg daily, the signal is the same for UIP and non-UIP pattern. However, for the 18 mg daily dose, you can see that the non-UIP patterns, the signal was stronger in favor of nerandomilast, but confidence interval are very large due to subgroup analysis, and we need more data to confirm these results. Can cluster analysis improve stratification? If you could try to separate patients in different clusters and try to see if the cluster are associated with either survival or progression. We did present some cluster analysis of RA-ILD 3 years ago at ACR conference. More than 1,600 patients with RA-ILD, retrospectively collected data from 13 countries, mostly Europe. We identified 2 different clusters. One were more European male, heavy smokers, older at RA onset, more seropositive, more UIP or NSIP, and the cluster 2 were more female, including other ethnicities, younger at RA onset, less positive ACPA and rheumatoid factor, and more alternative patterns. We are ongoing to look at the predictive, how could this cluster could predict outcome in RA-ILD. And I hope I will have some result to show you at the next ACR to see if this cluster could help to predict prognosis in RA-ILD. In conclusion, RA-ILD is an umbrella condition, encompasses a lot of different types of ILD, so it's not one disease, but multiple diseases. In patients, level and type of inflammation and fibrosis vary widely, and there is a strong heterogeneity that impacts prognosis and maybe treatment response. So it's very important to identify and study this heterogeneity. It's often under-recognized in literature, so sometimes it's hard to understand the paper that are comparing UIP to non-UIP, because non-UIP is a very heterogeneous subtype. And there is a clear unmet need today to identify high-risk or patients that are susceptible to respond to treatments. Thank you for your attention. And I'm happy to have any question.
Yeah. Thank you, Pierre. Great talk. Congrats on that. Do we have any questions? There are some.
Pierre, thank you so much. Fantastic talk, as always. Pooja Mehta from Yale. I was really interested in the differential effect of the antifibrotics in the radiological subtype. So as you really nicely demonstrated, there may be a differential effect of pirfenidone with UIP patients. And I think for years we've not known what the mechanism of action is of pirfenidone, but we know that nerandomilast has an anti-inflammatory effect, and also nintedanib may have an anti-inflammatory pleiotropic effect as well as being a receptor tyrosine kinase. What do we know, or do we know any more, about the mechanism of action of pirfenidone to explain that difference?
No, we don't really understand how it really works, so it's a great mystery of pulmonology, but maybe those results may help us to understand that it's really efficient in a clear UIP pattern with a UIP-induced mechanism compared to non-UIP fibrosis, which may involve different mechanism of fibrosis. Yeah. But it's a very interesting thing to see that in RA-ILD there is a clear difference of efficacy of pirfenidone. It may help us to understand how it works.
Thank you.
Hello, thank you for a good talk. May I ask about how important is telomere length in these patients?
Sorry, I couldn't hear you.
Telomere length.
Oh.
How important is, to distinguish UIP pattern and non-UIP pattern, especially fibrotic and SIP?
Okay, so it's interesting. It's a very interesting point. We performed a study again with the Boston group, international cohort with associated shortening telomere length to ILD in RA. However, in the telomere-related gene study, we did look at a very small group of patients where we had telomere length available, and the variants were not clearly associated with lower telomere length. We think that in RA, there may be a lot of confounding factors that may induce shortening telomere, inflammation, tobacco smoking, and maybe all those factors may shortening telomere in RA and may increase the risk of ILD in RA. But it's still not clear about the link of association. If it's just an association, or if there is a causal association between the telomere length and ILD in RA.
Okay, so I understand that your point is that we need more data.
Yeah, but it's also be looked at how telomere shortening is associated with pulmonary fibrosis in overall population. So in the overall population, there is a clear role of telomere length in pulmonary fibrosis. So it may be the case in RA-ILD, but what factors are causing this telomere length should be more deeply studied.
Oh, thank you very much.
Great talk. I'm from Japan. So I'm really impressed with your data regarding the trajectory analysis, which shows the 10 to 20% of the RA-ILD patient had poor prognosis. But unfortunately, you told us that there's no predictive biomarker at the baseline. So my question is, how about the 1-year follow-up, the data regarding which shows declines FVC? More than 10% of the decline of FVC could predict the long-term poor prognosis. Such kind of data might help us to separate the patient for the intensive therapy.
Thank you for the question. I think one thing that is quite clear in my mind, maybe it was not clear on the presentation, but that if your ILD is extensive or if it progresses, it will progress, that's for sure. For the identification of the FVC % as a predictive marker of the trajectory group, it also means that if you have a lower or higher FVC at baseline, you may also be more inclined to lose more FVC. So it's a bit tricky to clearly understand if it really impacts the trajectory group phenotype, but it should be more deeply observed. I think that one important point is that if you have a patient at baseline that have an extensive disease or a severe disease on PFTs, they will be at high risk to progress, that's for sure.
Okay, thank you.
Last question, quick answer, Pierre.
Yes, Jan Leenaerts, Belgium. Case 1 you presented with proven UIP. Do you stop the methotrexate, yes or no?
UIP, sorry?
So a very simple question. Do you, case 1, a
Yeah.
patient with rheumatoid arthritis, UIP, taking methotrexate.
Yeah.
Proven UIP, do you stop methotrexate or do you continue?
That's a huge debate that we could have a long presentation on, and I'm not sure I have time to respond. There is no clear recommendation on how you would use methotrexate in such severe patient. However, he has methotrexate for a long time, for years and years, so we did not stop it, but it's a very expert point of view, and I'm not sure we have literature to have a clear answer on that point. Thank you very much.
Thank you, Pierre. So now it's time to move to the next presentation. It's my great pleasure to introduce Dr. Jeffrey Sparks from the MGB Hospital in Boston, USA, for how to best identify our patients eligible for ILD screening. Thank you, Jeff.
All right. Wow. I'm so impressed at how many people are here. This is my favorite topic, and I was a little worried I'd be talking to myself, but it's really gratifying to see the interest. And I'm also very gratified to be invited to speak with this illustrious panelists, moderators, and really honored to go after Dr. Pierre-Antoine Juge, who actually worked with me for over a year, and to see how he's succeeded has been very helpful. And I think this has been organized very well, talking about the heterogeneity of disease. We're going to talk about screening, a very clinically actionable and maybe controversial topic, and then to end on treatment. So here are my disclosures. So I first want to mention that screening is inherently interesting and controversial because it's a risk-benefit balance. On the right here, you have some potential benefits related to early detection, perhaps improving quality of life, early intervention, reducing cost, and hopefully mortality. And this is often what many of the research is focused on. Are we accurate to find patients? Is there an intervention that modifies the natural history? Is it cost effective? Does it mean better quality and quantity of life? I will mention on the left side, of which is still as important, of course, and maybe not as researched as much. Pertinent to this are related to incidental findings on imaging, obviously the costs that go into imaging, perhaps excessive radiation, and then the psychological impact, because we do find some abnormalities on scans, and to tell patients that they have a nodule, that they remember that, and it can cause some anxiety, even if it's a small thing that's maybe not as consequential to us as clinicians. So this kind of just summarizes what I just said here. But in particular, I wanted to mention that to have a great screening test, you also need an early intervention. So we're really still early days here on RA-ILD, and some of the interventions to think about would be more intense monitoring, which by itself might be actionable to modify the natural history. And also, it'd be a dream to do an RCT in patients who we've found screen positive to see whether early intervention versus watchful waiting, which is the standard of care now, actually improves patient outcomes. Other things you might think about doing would be to minimize toxins, such as getting people to quit smoking, reducing pollutants, maybe reshuffling the DMARD deck, which by itself is very controversial, and then maybe vaccinations to prevent respiratory infections in people that have less respiratory reserve. Another thing to think about is diagnosis is not screening. So if patients are symptomatic, you should really go down a diagnostic pathway as opposed to a screening pathway. I will mention this is a really ambiguous area because respiratory symptoms are really hard to discern, and it's a gray line about who's symptomatic or not. I was going upstairs the other day and I felt a little winded, but I'm not sure that really counts as symptomatic. These are hard to measure consistently. As you know, there's been some recent guidelines that have been released on this topic, so I think it's good to get everyone on the same playing field. Coming from the US, I'll mention first the ACR chest screening guideline, and this is really among all SARDs. Basically, if you're at increased risk of ILD, you should be screened, and they recommended conditionally PFTs and HRCT. We won't get into the nitty-gritty here, but for the most part, it's thought that PFTs by themselves are not sensitive enough, and that HRCT is the gold standard. And then once you've diagnosed ILD, it's a different pathway from there. You can see some screening tests that were recommended against on the right that include plain chest X-ray, 6-minute walk test, desaturation testing, bronchoscopy, and of course, we're not using much lung biopsy. I decided to focus this talk mostly on who to screen based on risk factors as opposed to modality. But I will mention that this is also another rich area of investigation, particularly related to lung ultrasound. Certainly, ultrasounds are pretty readily available now, and many of us are trained for musculoskeletal ultrasound. And I don't personally do lung ultrasound myself, but I'm told it's not terribly difficult to learn how to do it and integrate that. So I think this does have a promise to be used as a screening tool in the clinic, kind of a point of care test. Also, a lot of interest in quantitative measures of HRCT using AI as opposed to the standard visual inspection. And then whether low-dose chest CT that we use in the US to screen for lung cancer among smokers might be something to repurpose for ILD. Other ones that I won't mention in great detail here. But you might also think about circulating biomarkers, some of which were already mentioned today. And also there's maybe some thoughts about even breath biomarkers, banking breath. Since we're here in Europe, of course, I have to mention the recent EULAR screening guideline. And I think the dichotomy here is pretty striking. On the left part of the screen are systemic sclerosis and MCTD. And these had a strong recommendation to screen all patients. Myositis with risk factors for screening. And you can see that RA is a bit in the gray zone here with a conditional recommendation to screen among people with risk factors. So that's what we'll focus on about why this dichotomy. And here are the risk factors that were recommended for screening in the EULAR guideline, and we'll go over some of the data that inform this. This is older age, typically 60 or older, male sex, smoking, higher ESR, increased CCP, rheumatoid factor, and higher articular disease activity. Actually, a pretty similar list was seen in the ACR chest SARD-ILD guideline. They did mention high titer rheumatoid factor and CCP. The only other difference was higher body mass index. So slightly different risk factors, but overall a lot of overlap here. I will also mention that there's a third guideline that is much more simple. So this is through the ATS. And they said, should adults with CTD undergo chest CT screening? And they said, we suggest a baseline chest HRCT scan to screen for all adults with CTD, and that includes rheumatoid arthritis. So that's pretty simple. They basically said we should screen every single patient. I'll mention this was approved by 36 out of 37, mostly pulmonologists. This does not seem to have the uptake, though, within the rheumatology community, and we'll get into that as well. I think Pierre showed the same slide here. A lot of this is related to the prevalence and differences in natural history. And again, the striking difference in the prevalence of ILD and systemic sclerosis and myositis, where it approaches 50%, whereas RA, at least in this study that showed clinically apparent ILD prevalence of 11%. And that's not thought to be as prevalent enough to want to screen every single person, given those risk-benefit issues that we talked about. So we'd really like to hone in, do risk stratification, where we find people who are at the highest risk and only screen those people and not have to worry about the other people. A little bit more about incidence, just to hopefully make you agree that this is an important issue. This is a nice Mayo Clinic study that looked at the cumulative incidence of ILD over 20 years of follow-up. Time zero is when articular RA is diagnosed, and you can see that ILD was diagnosed in 4% of patients before RA. So it's not that uncommon of a scenario for patients to hit your clinic already have RA-ILD. This also occurs in early RA. You can see that by 5 years of duration, this ticks up to around 7.5% cumulative incidence. And by 20 years of RA duration, nearly 1 in 6 patients had RA-ILD that was diagnosed clinically. This was not a screening study. This was diagnosed through clinical care. Also, an interesting thing about ILD, this seems to be one of the few outcomes that is not improving over the biologic era. I'll highlight this study from Denmark using administrative claims database. And you can see that the patients with prevalent ILD in gray have increased steadily over the biologic era from 2004 to 2016 during this study. Why this is happening is probably multifactorial. A lot of it might be awareness, more easily accessed advanced imaging, but maybe there's something biological about these patients. And certainly, even though our patients are doing better, have more expanded treatment options, ILD remains a major problem. And here it also illustrates this by looking at RA and cause-specific mortality on a relative risk scale. In this study, ILD was by far had the highest relative risk compared to the general population with a hazard ratio of over 3-fold increased. as you probably know, this also impacts survival, and as Pierre's also mentioned, a lot of heterogeneity in outcomes and trajectory, but looking at RA-ILD as a monolithic entity, an early study in the Mayo Clinic showed only 2.6 median survival. However, probably many of them were diagnosed very late into the disease. A more contemporary cohort on the right shows improved survival. However, compared to RA without ILD, the hazard ratio is still over twofold increased. So to me, this is still a big problem. We need to find the patients who are going to do the worst. So it's not just finding ILD, it's finding the ILD that's going to progress and need treatment and try to find them early. This was already very well illustrated by the previous speaker. For whatever reason, UIP has a predilection for RA compared to other SARDs. And you can see here that around 50% of RA-ILD has the UIP pattern, whereas many other of the SARDs have NSIP as a very predominant pattern. And there's really intrinsic interest about what is it about RA that puts it down the road to a more UIP phenotype. This was also shown before that this has typically worse natural history. I'll mention that one thing about screening is you want to understand whether people progress at all. So this is, I think, an interesting study that we led through the COPD gene study, which was a large study of smokers, over 10,000 who have had research HRCTs with longitudinal follow-up. And a subset of them had rheumatoid arthritis that we found. And actually, there's very few studies looking at a controlled study where there were RA cases and comparators to quantify the effect here. And you can see that in this study, 17% of RA patients had ILD. Nearly half of those were a fibrotic phenotype. And that's compared to 5% of people who without RA, and most of them had a non-fibrotic phenotype. So the odds ratio for subclinical ILD was 4-fold increased in RA and 8-fold increase for the fibrotic phenotype. And importantly, these patients were more likely to have higher mortality. The patients in red with RA with subclinical interstitial lung disease had nearly 3-fold increased death. Most of this was respiratory mortality. So patients with subclinical ILD do progress to ILD that also has clinical impact. This was also highlighted before, but I'll mention this single SNP that's really common has a really strong effect size for ILD. This MUC5B promoter variant, which is outside of the coding region, it basically expresses MUC5B at distal airways. And this is a high prevalence. Down 10 to 15% of people with European ancestry have the MUC5B promoter variant. And really strongly associated, it really has about, explains about 50% of the heritability of RA-ILD. And you can see here that this also co-localizes with honeycomb tissue in the lung and is specifically associated with the UIP subtype. And certainly nowadays, genetic tests are cheap to do, but hard to get clinically covered. So in theory, this could be a really easy to check marker that could help to risk stratify as well. Just to illustrate how important this variant is, this is a nice study from FinGen looking at the interaction of RA, sex, and MUC5B. On the left are men. In purple are RA and the MUC5B promoter variant. On the yellow is RA alone. Green is MUC5B in the general population, and gray is general population without the MUC5B promoter variant. And you can see that there's a dramatic increase with age, particularly once you hit the age of 60, and that men do have a high risk. By the age of 80, over 20% of men with RA and the MUC5B promoter variant had developed ILD. And while women have a lower risk for ILD, older women are still at risk. You can see here that after the age of 60 in women, that risk also goes up while not as dramatically in men. And we wonder whether there could be menopausal factors or things about female biology that could be protective. Now looking at some other risk factors, disease activity, obviously this is something that as rheumatologists, every visit we're trying to understand how active is their RA, and that's really why we're switching medications. And so we wondered whether this was associated with future risk of ILD using a local cohort called the Brigham RA sequential study. And these were the top-line results. You can see that moderate or high disease activity was associated with a 2-fold increased risk of incident ILD. When you look at the ordinal scale, you can see that there's a nice dose effect and that the high disease activity category had over a 3-fold increased hazard. And also on a continuous scale, for every point increase of the DAS28, there's a 35% increase in ILD risk. So this suggests that people who are in moderate or high disease activity for some portion of time that this could be also, the systemic inflammation could be fueling some lung disease. And you wonder whether there's specific meds that could help here. I'd say overall, getting people to remission or low is the first order of business. And we can debate about whether the specifics of medications are about their lung health. So even though we have a lot more to know about RA-ILD, we've identified many risk factors. And I've listed here in another study in BRASS, looking at age, sex, education, smoking, pack years, obesity, and many RA factors related to seropositivity, disease activity, medications, functional status, and extra-articular manifestations. And granted, this was a single data set, probably overfit, but overall, it had really decent predictive ability. And in theory, these are factors that would all be readily available to you as a clinician right now. Pierre also highlighted this study, but I think an issue with the research has been that we've looked at RA-ILD mostly as a monolithic entity, and this is one of the first studies to look at specific risk factors for subtypes based on HRCT pattern. And the thing that most struck out is that the UIP pattern was the only pattern that had an association with older age, and also was the only pattern that had that striking association with male sex. So I'll march through some risk scores that have put together some of these myriad of different factors. The first that I'll highlight is the VERA RA-ILD risk score. This was developed in this mostly male veterans population, of which many heavy smokers. And they looked at a genetic risk score that included the MUC5B promoter variant as well as 4 other SNPs, and then other relatively easy things to measure: older age, smoking, male sex, DAS28, and rheumatoid factor positivity. This was actually recently externally validated in a Swedish cohort that was a more typical demographics for an RA population, and I'm actually showing the validation study here that actually showed an AUC of 0.75. So overall, looked pretty promising. And now I'm going to tell you about some studies that are prospective, looking at screening studies. The first I'll mention is a sub-study of our BRASS cohort called BRASS Lung, where we invite people in for research CT scans. We've now done 145 scans. Most of these people have pretty prevalent RA with a median RA duration of 18 years. We are in the midst of doing 2-year study follow-up visits to look at progression. But interestingly, these are people who had no diagnosed lung diseases, and 44% of them had subclinical parenchymal lung disease. And you can see the spectrum of disease that's shown here. So even though the session's focused about ILD, RA can seem to affect many different parts of the lungs. And in this cohort of people with, again, long duration of RA, mostly in low disease activity, the prevalence of subclinical ILD was 15%. Now I'll highlight some of Professor Diodé's work, looking at 2 French RA cohorts trying to develop a risk score for subclinical RA-ILD. So these were separate cohorts, SBAR and Translate 2, and basically these people had no symptoms, came in for a research HRCT, and they found 19% and 17% prevalence of subclinical ILD respectively, and these same risk factors fell out. The MUC5B promoter variant was strongly associated, male sex, older age at RA onset, and higher disease activity over follow-up. And actually, the AUC was quite good here with 0.82 and 0.78 respectively. And actually, this is probably one of my favorite figures to illustrate risk stratification here. To orient you, on the columns is disease activity in 3 levels, low, medium, and high, female, male, sex, and on the rows are age at RA onset, early onset, middle age onset, and older onset, and then the MUC5B promoter variant present or absent. So people who are clustered on the left corner have very few risk factors. People in the lower right corner have a lot of risk factors. And as far as the extremes, if you had no risk factors, your probability of having ILD in the scan was only 2%. Conversely, if you had all 4 risk factors, the probability of having ILD in the scan was 95%. Clearly, you would want to scan and follow the person with the high probability, and the person with low probability, you wouldn't really need to worry about it. I think the issue comes, where do you draw the line? And obviously, there's a lot of yellow here and a lot of options. The other issue is the MUC5B promoter variant is not currently clinically available. As an aside, they did do another very similar figure to this without the MUC5B promoter variant, and the risk stratification does still hold up. I'll tell you about our ongoing SAIL-RA study, which is funded by the NIH, and we're focusing on patients with new onset rheumatoid arthritis to look at lung health over early RA. So we try to enroll people as soon as they're diagnosed to get a research chest HRCT, PFTs, et cetera. We see them every 6 months, actually, and then we do a repeat 2-year final visit. I also have to mention, I'm really proud of our logo here. It has some Easter eggs. The sails are actually lungs. You can see the fissures on the right lung. There's 2 fissures, 3 lobes. On the left lung, there's two lobes as well. And the whole of the ship is actually a joint, and the wave is a synovitis. So just really proud of that. Anyway, we're excited also to share the baseline results. So again, these are people with median RA duration of 3 to 4 months and do not have diagnosed lung disease. And we phenotyped them to see who had subclinical ILD, and 11% of patients had subclinical ILD. Looking at the odds ratios, and again, we recapitulated many of the risk factors already mentioned: older age, male sex, although not statistically significant here, as well as a striking association of moderate or high disease activity. And we decided to do external validation of screening strategies listed here. Anchor RA that I'll mention later, the ACR chest guideline that was already mentioned before, SBAR that was mentioned before. As an aside, many of the risk factors we found in CellRA were identical to SBAR, as well as the 4-factor score, which is a weighted system related to age, smoking, rheumatoid factor, and CCP titer. We decided to look at a sensitive cut point of 1+ factor, and we found that this was quite sensitive in CellRA with 95% sensitivity and 30% specificity, and a number needed to screen to find 1 ILD case of 6.6. Then we decided to look at a strategy to enhance specificity so that you would count more risk factors, so 2+ factors. As expected, the sensitivity dropped slightly to 79%, and the specificity raised higher, slightly to 73%. And at least in our CellRA cohort of people with new onset RA, this was an efficient method to screen, where only 3.6 scans were needed to detect 1 ILD case. To also show how efficient this was, among the study sample, we were able to would only have to scan 54 patients to find 15 of the 19 cases using the CellRA criteria. And then using other models, some that I didn't mention here, including the pollen criteria and the SIR-SEPAR, actually the AUCs were quite good, many of them hovering around 0.8. So perhaps we do have a risk model that could be useful. And now I'll mention a study that was presented yesterday that I was very excited to help lead, the Anchor RA study. This was a global international prospective study sponsored by Boehringer Ingelheim, 27 sites across 6 countries, and actually really mirrored what happened with the guidelines, where consecutive patients with at least 2 ILD risk factors, male sex, older age, smoking, high positive antibodies, extra-articular RA, or high RA disease activity. So out of 1,196 participants, this study found 106 who had ILD, or 9.1%. And I have to say, this has been a debate about what would have been expected, because this is an enriched population, this isn't all comers. But I'll mention that, of course, people who are already diagnosed with ILD were not eligible, and perhaps this did not really select the population as much as we thought, that I'll get to later. These were the characteristics that were associated with ILD and Anchor RA. Many of them were very similar to what we've already talked about: older age, male sex, smoking. Of course, ILD features such as lower DLCO, lower oxygen saturation, having crackles, the MUC5B promoter variant, older age, high disease activity, and rheumatoid factor. So I wanted to highlight a poster that was just presented by our next presenter, Dr. Hoffman-Vold. And what they did is looked in a Swiss quality register to see how many people actually had the risk factors that were recommended by EULAR. So interestingly, in this study, nearly 80% had at least 2 risk factors for ILD. So this argues that perhaps this isn't selecting the population quite enough for risk stratification. I'll mention that their cohort was highly seropositive compared to ours, and again, the CellRA study was very new onset RA, so perhaps had some different demographics related to that. Another thing that we've looked at is opportunistic screening. So as you probably know that, at least in the US, the low-dose chest CT is recommended to screen for lung cancer among smokers. Smoking is a risk factor for ILD. So we decided to look at the local experience among all consecutive patients that had low-dose chest CT screened. We identified 228 patients out of around 15,000 that had low-dose CT scan. And you can see that RA patients were more likely to have a positive screen. This gets a hint about some of the downsides of perhaps incidental findings. Interesting, lung cancer was not different, but maybe numerically slightly higher in RA as expected. And probably as expected, fibrotic changes in bronchiectasis were more likely to be found, and this was only seen within the seropositive subset of RA. So that gives you a hint about what a screening program might find. So I think I have time for questions now, but hopefully there's a lot of, we have a lot of more work to do, but we've made a lot of progress in identifying risk factors. Again, we need to routinely assess for symptoms and auscultate for crackles. We have 3 guidelines that, the ATS recommending all patients to be screened, but the rheumatology organizations recommending risk factors. And we still need to find models to find progressive ILD. It's not necessarily all the ILD patients that we need to worry about. And then again, we need an intervention that will modify the natural history and to quantify the benefits and harms of ILD screening. And with that, I'll look forward to your questions. Thank you.
Thank you, Jeff. Great talk. Is there any question from the audience? No, so I have one for you. How many risk factors justify for your screening? Which is the cutoff that you will use in your clinical practice?
Wow. Well, we tried to do 2 risk factors in Anchor RA, and I think we're still in the midst of analyzing. I think counting risk factors may be too simple. I think a weighted score might be more useful. There's also issues with overlap. Perhaps many of the smokers are also men, so if you count those as independent, you might be double counting but not actually getting much more bang for your buck. So I think in a perfect world, we would have a weighted risk score that's really going to risk stratify. Those can be hard to implement. You often will need a calculator in clinic to really do the math as opposed to counting, which is much easier. Another alternative strategy is to just do a higher threshold, maybe 3 risk factors, but of course, you'll sacrifice some sensitivity as you get more specific. So this is the state of the art. We've found many risk factors. We need to figure out how to combine them into a score that will be replicable and implementable.
Thank you. One additional question from my side. A challenging question, sorry for that, but do you have any clues to indicate what will be the optimal timing for screening according to the RA duration? This is a key question.
That's a good question. In SailRA, we focused on new onset RA just because it was a natural time to think about risk. I do think that is, I think the SailRA data are promising to show that perhaps that is a good time to consider screening. The other thing is, as I showed with the Finnish data, age is such a strong risk factor, similar to colorectal screening and breast cancer. People really aren't at a high risk until they hover around 60 years. So I think also considering, people who are nearing 60 years old might be another natural time to consider screening in RA-ILD.
Please go to the mic.
Hi, I'm Peter Corsten from Germany. A great talk as always. To identify progressors, you mentioned that it is important. Do you think that the use of wearables is a way to go? I don't think there's any data, but it might be feasible.
You said wearables?
Wearables, like Apple Watch or whatever.
Yeah, those can measure oxygen saturation. That would be a promising idea. I haven't thought of that. I think for the most part, we're thinking about the MUC5B promoter variant because of its strong association with UIP. And then, the circulating biomarkers of pulmonary damage biomarkers such as KL6 and MMP7. But I do think we also need to develop risk models for UIP. Clearly, they have the worst natural history and the patients you worry about most.
Thank you.
Hi, my name is Shazam, one of the internal medicine trainees from the UK. My question was, for those people who have a first-degree relative with a MUC5B promoter variant, without RA, could this be the population we could screen for RA-ILD then in the future?
All right, let me get that. So family history of ILD and the MUC5B promoter variant. In theory, those patients could be at risk. They're really at most risk of ILD, of course. I think RA would probably be maybe slightly increased, but you'd really much more worry about the lungs. But there is a lot of interest in people with familial pulmonary fibrosis because they have such a high incidence of subclinical ILD and whether early intervention would be warranted. And I believe there's talks at least about doing intervention studies of antifibrotics in that population. I also think it would be a natural study, when we're doing these research studies for screening, finding them, that would be really a good opportunity to do a trial, because at the moment we really don't know what to do, and that's kind of equipoise. So I think in our screening studies, if we could embed a trial of maybe perhaps early antifibrotics versus watchful waiting, that would really be important.
Thank you.
Thank you, Jeff.
Thank you.
So our next speaker is Professor Anna-Maria Hoffmann-Volt. She's the head of the Inflammatory and Fibrotic Rheumatic Disease Research Area in Oslo, Norway, and also the leader of the Translational Research Group in Zurich, an absolute expert in CTD-ILD, and she's going to talk about the impact of the ERS EULAR guidelines in the management of RA-ILD.
Thank you very much, Kazi, for the nice introduction. Thank you very much to EULAR to invite me to talk about how to implement the guidelines into clinical practice. I'm really struck by the huge interest with a full room. Of course, it's a nice panel of speakers. I'm delighted to talk after Jeff and Pierre, but it's really, really nice to see that the interest in ILD and RA also increases so much. Here are my disclosures. And what I will talk mainly today about is what I was asked to talk about: how do we actually implement the guideline into clinical practice? And you most likely all of you have seen that the guideline is published. This is the algorithm which we provided for the treatment of RA-ILD. And I would very much like to walk you through how you actually can implement it in clinical practice. And I was very delighted to hear that Pierre already made it very easy for me, because we also build up the entire guideline by identifying the right phenotype for the right drug. And this is what I will show you in the next slides. So if you have an RA patient, an RA-ILD patient in your clinic, you should first assess the articular disease activity. That is really the first step in the entire guideline. So look at your patient. Do you have a patient who has active articular disease activity? Then you have the light pink patient, or do you have an RA-ILD patient which has well-controlled arthritis? That will really help you also to guide how to treat the ILD in the specific patient. Then the next step, and I think this is really important, and you have learned a lot from Pierre and Jeff about that we need to identify the patients who are at high risk of progressive ILD. We need to identify them before they actually progress to really also adopt the right treatment for these patients to prevent a progressive ILD course with the increased mortality it follows with, which was very nicely highlighted in the two talks before. And how do we do this? I will also come back to this, but it's what we provided is that we went through the literature, we identified by a very robust methodology what are the risk factors which had been identified in 2 or more publications, and we summarized them for every disease, and these are the ones for RA-ILD. So if you have a patient with a male sex, older age, high titer anti-CCP RF factor, low baseline FVCs, UIP pattern, you very nicely heard that in the previous talks, and higher disease activity, these patients are the ones who have a higher risk of ILD progression compared to the ones who don't have these risk factors. So that is also a next step after the articular disease activity. And then we also have the different phenotypes by not only the risk of severe progressive phenotype, but we also have the phenotype of progressive pulmonary fibrosis and the phenotype of UIP pattern, which you very nicely heard about from Pierre, why it is so important to identify these patients. So that is really the first step you need to do before you assign the right treatment for the right patient. So that is all what I just said. Based on this algorithm, which we published in the guideline, look at the right treatment. So how do we do this? So let's start with a patient who has a presence of active arthritis. We need, of course, to treat the joints, treat to target, following the EULAR guidelines. But we should also, at the same time, use one of the drugs which also targets the lung. And how do we do this? But before we go to exactly the right immunosuppressive, I want to highlight two things. There was also a question from the audience what to do with methotrexate. And methotrexate is still a matter of debate. I completely agree both with Pierre and Philippe, which was just said. But what we also need to appreciate is that the novel evidence which comes shows us that it's most likely not harmful to our patients with RA to keep them on methotrexate. This is one study which is published which showed that RA-ILD patients being on methotrexate have a better survival over time than compared to patients who are not on methotrexate. There's another study showing that RA patients on methotrexate have a lower incidence of ILD. So this is why, in general, we now say that you can use the treat-to-target for your joints. You can use methotrexate. Of course, and I completely agree with the case which Pierre showed, if a patient has severe ILD and is on methotrexate, that patient would be one I would discuss with a pulmonologist in the MDT meeting and to discuss what to do in that specific patient. The next question is, of course, anti-TNF, because that is, of course, also treat-to-target for the joints. And for the guideline, we didn't have any evidence available, so we don't mention it in the guideline. But as you can see here from the Veterans Affairs, there's a very nice study published in 2025, so after the guideline, which looked at in the patients with RA-ILD from the Veterans Affairs who were treated with anti-TNF and compared these patients with rituximab and abatacept. This is an emulation trial. Both groups were propensity match scored, more than 1,000 patients. And what they looked, when they looked at all the different outcomes, so hospitalization, death, and respiratory death, and compared the two groups, there was no difference in the anti-TNF treated patients. What that means is that if you have an RA-ILD patient where you just want to control the articular disease activity but not the lung, the anti-TNF is at least not harmful to our RA-ILD patient based on this data. And I think that is something which we have been lacking of evidence so far. Then let's move on. If you have now a patient with active arthritis and ILD, and you really also want to treat the ILD, what can we use? And unfortunately, compared to systemic sclerosis, there are no randomized clinical trials. So the entire evidence from the guideline is from single cohort studies, retrospective data, looking in the charts what we did. With all these limitations, the immunosuppressives which we identified using our robust methodology were abatacept, rituximab, and JAK inhibitors. Small studies, retrospective, but these were the drugs which we identified as immunosuppressive published. This is why they're highlighted in green here. Then, and I will walk you through the data we have based on this. Then, as you can see in white boxes with blue frames, these is including tocilizumab, steroids, mycophenolate, azathioprine. We did not identify any evidence which we could include. After that, again, some were published, which I will walk you through to really see whether these are drugs which we also could use for the treatment of both. So first, a small study, 14 patients with RA-ILD treated with rituximab compared to 14 patients not treated with rituximab. We did not find an in-between group difference. So it didn't show that rituximab really had a positive impact. But when you look at the data, you can see a slight improvement in patients in light yellow. These patients were on rituximab at baseline compared to 12 months data. You can see a small increase in FVC compared to the patients not on rituximab who slightly declined. But the in-between group was not significant, but at least it shows us maybe a trend that rituximab might help. The safety profile was also quite fine. The study looking at JAK inhibitors compared to abatacept, again, single center, small cohort. There, first, the CDAI improved, not surprisingly, in both drugs. When we looked at the lung function changes and HRCT changes, we didn't see an in-between group difference. So both of the drugs seem to have an improve or a stabilization more or less on lung function and HRCT. When we looked at the respiratory symptoms, dyspnea, again, both of the drugs in that study showed an improvement. Also, the HAQ-DI actually improved in both drugs in this small study. So this is the basis why we included these 3 drugs in the guideline. As I told you, tocilizumab, which we also think, if we transfer the knowledge from, for example, systemic sclerosis, might be a good drug to treat both joints and lung. There is a study very recently published in CHEST, which I now include here in the trial as maybe supportive evidence, where they also, again, used an emulation target trial, propensity score matched 2 groups, one group treated with tocilizumab and one group with rituximab. Again, they looked at all different outcomes, and there was no difference in tocilizumab compared to rituximab. So it looks like in this trial that also tocilizumab has the same efficacy as rituximab. However, one very interesting finding in this study was that if they looked at a subgroup of patients who had high inflammatory disease activity, it looked that these patients had a worse outcome in tocilizumab. Personally, to me, and I also discussed this with Philippe the other night, we both thought it was a little bit counterintuitive because we would think that patients who have a high inflammatory phenotype would maybe also respond to tocilizumab, so a bit unsure why, but this is something we always need to take into account. The phenotype is important. Also coming back to what Pierre said, we always need to look at the phenotype and then decide the drug. When we look at mycophenolate and azathioprine, there is no published data out which meets the criteria of a guideline, really looking at a group treated and non-treated. But there is a study from Matson, which was published in 2023, where they looked at the disease trajectory pre- and post-treatment with mycophenolate and azathioprine. And you can see in both drugs, it looks like that the trajectory actually changed after the initiation of treatment. However, when you look at the p-values, it only showed significant effect for mycophenolate and not azathioprine. And I think this is important to remember, that there is no evidence for azathioprine so far, and also in Norway we don't use it as a treatment option for RA-ILD, but I know around the world some countries still do. But always remember, what do we have evidence for and what not. And then going to the next phenotype, using also immunosuppressives, I told you that we really want to identify the patients who are at high risk of progression. We would really like to be able to prevent progression in RA-ILD to improve survival over time. And what we recommend in the guideline is to look at the published risk factors, and if a patient has 2 or more risk factors, or look at them as a high-risk patient and treat them more aggressively. The combination therapy, which we suggest in the guideline for the high-risk patients, is the combination of rituximab and mycophenolate. That is based on the French EVER-ILD trial, which included idiopathic NSIP patients, CTD-ILD patients, a couple of RA-ILD, not many, and some IPAF patients. And what it showed was that the combination of mycophenolate and rituximab had a better effect on lung function than only as monotherapy. Also, the side effect profile was quite okay. Of course, some more infections in the combination therapy. When they looked at progression-free survival, also again here, the combination therapy of rituximab and mycophenolate had a better effect than only mycophenolate. So again, also supporting not an RA-ILD trial, but giving us supporting evidence that in the really high-risk patients for ILD progression, we should always also consider whether to treat this patient with combination therapy. And then the next phenotype, if you remember what I showed you, was progressive pulmonary fibrosis. That is a standing term in pulmonology. The pulmonologists invented these terms a couple of years ago, and I also know that in rheumatology it is not so implemented yet as in pulmonology, so therefore I also included here the definitions. What it more or less says is that you have a patient with RA-ILD who worsens in more than one compartment. So that patient has worsening in lung function, worsening on CT, worsening respiratory symptoms in a combination. So that also tells us, of course, which we also heard, you need to monitor your patients using several modalities. And if you identify a patient who worsens in 2 or more of these compartments, that is a progressive pulmonary fibrosis phenotype patient. In the guideline, we recommend nintedanib in the use of these patients because this is approved therapy around the world. That is actually the only really approved therapy we have for RA-ILD, coming with data from a randomized clinical trial. So these data are much more solid than all the immunosuppressives I showed you and all the immunosuppressives we often use. So that means if you have a patient with a progressive pulmonary fibrosis phenotype, that patient should be treated with nintedanib based on these data. And there's also some published data because the trial was, again, an umbrella term trial including all different ILD phenotypes, but it's also published. The data on RA-ILD are published, and you can see here it really nicely shows that nintedanib reduced the progression in RA-ILD compared to placebo. What was also very nice in that trial, underlying RA treatment was allowed. So a couple, or quite some patients were using methotrexate, anti-TNF, and steroids. And even adding nintedanib on top of the standard of care RA treatment had a treatment efficacy for slowing ILD progression over time. Also, the adverse events is always something we need to consider, and this is maybe also something why nintedanib is not that often used by us rheumatologists, is because we know there is quite a lot of diarrhea. But again, I always also say, talk to your patients, talk about the impact of having progressive ILD compared to side effects, and decide together with the patient what makes sense for that specific patient. And then you have heard a lot about the UIP pattern, and Pierre really nicely showed you, and also Jeff really nicely showed you, these are the patients we really want to identify. An RA-ILD patient with a UIP pattern has a very high likelihood of being progressive over time. So that is also both a risk factor for progressive pulmonary fibrosis with the use of nintedanib, but what we also know is that we have another drug which we can use in a UIP pattern patient. And that is pirfenidone. And you have already also seen the trial in both in Pierre's talk, and that is a trial which was conducted in the US where RA-ILD patients were randomized to pirfenidone or placebo. So that is the second RCT randomized clinical trial which is conducted in RA-ILD, which showed that pirfenidone in RA-ILD with the UIP pattern very much reduced the FVC decline over time. And here you can very nicely also see, again, supporting what Pierre and I have said, that the UIP pattern without treatment is the most progressive patient. You can see this in dark blue. These are the patients who received placebo, and they lost 107 milliliters over 1 year. That is a huge loss, coming quite close to idiopathic pulmonary fibrosis. And when these patients were treated with pirfenidone in dark red, you can see the FVC decline really slowed. This is a drug which is not approved, and it also depends very much on the country whether you can use it. But if you have it available, also consider it next to nintedanib in these patients. So if we look at back to the algorithm, this is what I walked you nicely through, I hope, how you use the guidelines in the future, or from now on. Look at the patient, do they have active arthritis, then treat to target, based on whether you also want to treat articular disease activity, then you have a couple of drugs which have shown very low evidence, but still some evidence in observational trials. If you have an RA-ILD patient well controlled, where you don't need to treat the joints, look also for the other phenotypes. Is that a progressive pulmonary fibrosis patient? Is that an at-risk patient for a progressive ILD? Does the patient have UIP? Based on this clinical phenotype, you choose the right drug for the patient, and very importantly, you need to monitor your patient. Every patient of our RA-ILD patient has a risk for progressive ILD, and we need to identify this. So monitor your patient closely over time using lung function, HSCT, respiratory symptoms, exercise capacity with a 6-minute walking test, desaturation. If the patient meets your predefined treatment goals, continue the treatment you chose. If the patient shows no treatment response, you need to reconsider your treatment. And there is no data at all for second-line treatment, which we identified in the guideline. So this is why we just have some suggestions for you. So switch or add on therapy based on what you have given before. If the patient has progressive pulmonary fibrosis, add nintedanib. Don't use, of course, biologics in combination, things like that. And hopefully in the future, we will have more data to support also second-line treatment. And as you also know, we will have more medications in the future which will be improved, such as nerandomilast, which showed efficacy in progressive pulmonary fibrosis across all autoimmune ILDs. So that drug will also be placed in the updated guidelines. And there are also many, many other trials ongoing, which now include RA-ILD patients. So my take-home messages are: look at the clinical phenotype of your patient, assess articular disease activity, look at the ILD severity and risk of progressive pulmonary fibrosis, base your treatment choices really on your clinical phenotype. And I'm so glad that this was highlighted through all the 3 talks, that we need to go much more into personalized medicine when we talk about RA-ILD. It's not one entity, as you very nicely heard at the beginning. Immunosuppressive therapy is recommended in patients with RA-ILD. RA-ILD at risk of progression are recommended to be treated with a combination of their immunosuppressants. RA-ILD patients with a progressive pulmonary fibrosis phenotype should be treated with nintedanib alone or in combination with immunosuppressive. And if you have an RA-ILD patient with a UIP pattern, we also recommend here either nintedanib or pirfenidone. Thank you very much for listening to me. I'm thankful for all the groups I've been working with. I'm thankful for the chairs and my co-speakers, and I hope you have some questions which we can discuss. Thank you very much.
Thank you, Anna. Excellent talk. Do we have questions? Yeah.
Okay. Hello, my name is Hans. I'm from Switzerland. Thank you for your excellent talk. If you have a patient that has not only RA but a CPPD, and you have high sedimentation rate, and he has active disease in the neck, not in the joints, but he has approved pulmonary fibrosis progression with an RA standing for years under methotrexate, is just nintedanib your choice, or would you escalate the RA therapy with the question mark?
Thank you very much, and great question, because then you suddenly have 2 clinical phenotypes. You have the active arthritis, which you really need to treat, because as it was also shown in the previous talks, active arthritis is a risk factor for progressive ILD. So you always need to optimize the treatment for the underlying active arthritis inflammation, as you said. But that patient would then also be someone where I would also consider nintedanib very early if that is a fibrotic pattern with a progressive phenotype, yes. So that is, of course, a patient where you should consider both, yes.
Thank you.
Thank you.
Hello. Congratulations. Maria Luisa from Brazil. Anna, I would like to know about your experience with JAK inhibitors.
Thank you very much. That's a very great question. So far we have very little experience with JAK inhibitors and RA-ILD. The evidence is really very little what we have. But when you look at also what is known from the molecular landscaping in our patients with ILD, it looks like the JAK-STAT pathways are upregulated. So you would really target immunosuppression at a high level. So it makes a lot of sense, personally to me, despite lacking evidence. Personally, I have very little experience because we treat very few RA-ILD patients with JAK inhibitors in Norway right now. But I think it's a promising drug, personally, even in the lack of evidence so far.
Hi, that was a great talk. My name's Carmel Stober from Cambridge, UK. I just wanted to ask you actually about an ACPA positive patient with no clinical articular disease with ILD. What would be your approach?
Thank you, great questions. We have these patients quite often in our MDT meetings. They then very often come from the pulmonologist saying, we have an ILD patient, we have the hint of some autoimmunity, we find the ACPA positive patient, antibodies. That's a very classical patient for us too. Only treat the lung. The patient does not have RA yet. But we also know it's a very high risk factor for developing RA. So what we usually do is also instruct the pulmonologist to talk. Well, sometimes we even consult the patient, really make sure that the patient does not have articular disease. And then if the patient really does not have any articular disease, we would instruct the patient to really see, do the patient get morning stiffness, does the patient get swelling of the joints, and contact us immediately if they develop articular disease activity. But we would at that time point not treat articular disease activity. We would really then treat the lung and see is there any signs of inflammation. Then we would also in that patient even use an immunosuppressive, or would we go straight to nintedanib at that patient. But that is then really based on the ILD because we don't have an RA diagnosis underlying yet.
So you wouldn't use MMF, for example?
Might be, right? If that is a patient where we really see it is kind of high immunity, there is inflammation, has ground glass on CT, whatever that means actually, but it really is not the fibrotic pattern ILD where we think nintedanib. That could be a choice, yes. But we don't have evidence, right? But this is something we would discuss together with a pulmonologist, but might be. But very much depending on the clinical phenotype of the patient.
Thank you. So sorry, this is the end of this session. So I would like to thank the speakers for the great talks and thank the audience for your interest and very fruitful discussion. Thank you.